I'll be presenting an update on our first-in-human phase 1 study of this bispecific antibody, REG1979. And it's a bispecific antibody that binds CD20 on B-cell lymphomas and CD3 on T cells. We've presented data on this study before at ASH, but the update this year is that we've completed our dose escalation of the study, and we have not seen any dose-limiting toxicities. And so we've actually taken the study to the highest planned dose in our protocol. In addition, we'll be presenting some data on a few patients who have then moved into our expansion cohorts, which are part of this study as well. In the study, we dose patients with a step-up dosing strategy so that an individual patient is dosed over the course of 4 weeks at incrementally higher doses, reaching their full assigned dose at the end of the 4-week period. And using this strategy, we've minimized a lot of the toxicity that potentially we may have seen. We were focused on cytokine release syndrome as a potential toxicity, and we do see that. Primarily grade 1 and 2 toxicity, few grade 3s, and all of that toxicity, when it does occur, is in the first few weeks of treatment, paradoxically at lower doses of drug, and the toxicity occurs early, and we're able to then take the patient to a higher final dose of drug. And using this strategy, as I said, we've gotten to the highest dose that we had planned to look at without any dose-limiting toxicities. We've also seen, importantly, some neurotoxicity, but again, all of that has been grade 1 and 2 for the most part. A few cases of grade 3 neurotoxicity and no grade 4 or above neurotoxicity. So we have a drug that's looked safe in our dose escalation study. Looking at the activity of the drug, we're looking at very heavily pretreated patients with various B-cell non-Hodgkins lymphomas. In this study, about 2/3 are large cell lymphoma, about 1/3 are follicular lymphoma, and then we have a smattering of some other diagnoses, including mantle cell lymphoma, marginal zone lymphoma, and even less frequent ones. In the follicular lymphoma patients, we have, again, a very heavily pretreated group. We've seen very promising activity. We have close to 100% response rate in this analysis, about 96%, and a very high complete remission rate as well in that group. In the diffuse large B-cell lymphoma patients, we looked at patients who had received prior CAR-T therapy and also patients who had not received prior CAR-T therapy. And in both groups of patients at our higher dose levels, we have very promising activity. Again, high rates of overall remission, overall response rates, and also very high rates of complete remission in the non-CAR-T population, and very promising CR rates in the CAR-T population. We're seeing activity in patients who've really become very chemotherapy refractory, and in some cases refractory to other immune strategies in the setting of the CAR-T. Finally, tomorrow we'll be presenting some data, which I think is an important part of these types of studies. We've had paired biopsies, and we've also asked for biopsies at the time of disease progression. And so with these serial biopsies, we've looked at some biomarkers, and tomorrow I'll be on Monday I'll be presenting data that may suggest some possible mechanisms of resistance to bispecific antibodies that we see on the basis of these paired biopsies. And so one obvious mechanism is loss of antigen, so you lose the target antigen, and the patients become resistant to this type of therapy. Another less obvious type of resistance are in patients who continue to maintain the target antigen, but they become resistant to treatment. And in those patients, we see clear activation of checkpoint pathway with upregulation of PD-L1 and PD-1. And so we'll be sharing some of that data as well. Right, so that's a question for everyone, certainly for the sponsor, but for us academics as well. With this drug, the level of activity that we're seeing, I think, would support monotherapy in these multiply relapsed patients, and we know there are a number of agents out there now that are approved second line and beyond. For example, the PI3 kinase inhibitors in follicular lymphoma. So I think in that setting, as a monotherapy, we have a very active drug. It could be used well there. In the setting of CAR T failures, a very refractory population, we have activity including complete remissions that are durable, so that would be another setting where this drug could be used as monotherapy. And then there are really a host of potential combinations where it could be combined with other drugs and used in earlier lines of therapy. One combination that our data that we'll be presenting suggests is combining with checkpoint inhibitors, since we see upregulation of PD-1, PD-L1 in patients treated with this drug. Combining with a checkpoint inhibitor makes sense as an obvious next step. So I would just say that our study continues in expansion cohorts, and we will be looking at ways to optimize outcome based on treatment sequence in the phase 1 expansion cohorts, and the sponsor has already opened a phase 2 study choosing doses from the study that we've just completed that are going forward in follicular lymphoma, large cell lymphoma, and other lymphoma subtypes.